Bismillah ar-Rahman ar-Rahim. I'm Hany El-Deeb. I'm going to give you a lecture about coma, clinical approach to coma, and disturbed level of consciousness. First, we need to have some basic issues to be mentioned, that the story is not simply a conscious and unconscious patient. Actually, it is a spectrum of consciousness, starting from a fully conscious, fully attending patient to the surrounding environment, ending in a patient with deep coma. So, to start with, we have to start with some basic knowledge about the consciousness, what is meant by consciousness, and what are the contents of consciousness, and what are the items of the spectrum of disturbed consciousness from fully conscious patient, as we said, to the state of deep coma. Simply, consciousness is defined as the state of awareness of self and surroundings. It means that I'm fully conscious, I'm attending my surrounding environment, my colleagues, my friends, and I'm going to communicate perfectly with the surroundings. To have a full conscious patient, the patient requires both the state of arousal, of being or looking awake, and the state of intact mental content. It means that we need the integrity of both the reticular activating system and the cerebral cortex. The cortex is responsible for the content of consciousness. It means the sum of all the cognitive and affective functions of the patient, and basically the state of awareness or wakefulness, and this is the arousal or the function of what is called the ascending reticular activating system. So the content depends on arousal, but not the opposite. It means that normal arousal doesn't guarantee normal content. Simply, the patient, if having some problems in the cortex, in both cortices, the patient may look aware, but actually he's not he's not aware. He's having the picture of being aware, but actually the content of awareness is not present. So the arousal damage, if there is a damage affecting the state of arousal, the patient may present with coma or semi-coma or delirium, and these terms will be explained. But if the content is damaged, the patient may present with the problems that affect the content of consciousness, like delusions, like confusion, inattention, and dementia. So, as we said, it is not simply conscious and unconscious. It actually is the state of consciousness, starting with a fully alert, fully conscious patient that responds perfectly, normal response to all the surrounding stimuli, either verbal, either painful, either non-painful. Any stimulus will be given to the patient, he will respond perfectly to it. This is the alert, fully conscious patient. There is the opposite, complete opposite, is the state of coma. It means that the patient is completely losing his responsiveness to all the stimuli, either verbal, either oral, either painful, either any type of stimuli are not responded by the patient actually. In between these two extremes, we have many points. We have the state of stupor, for example. The patient in stupor having a baseline unresponsiveness actually. But if the patient received repeated vigorous stimuli, either verbal or motor, the patient may achieve arousal. This is the state of stupor. The state of semi-coma, the patient here is not responding unless he's receiving a very painful motor stimulus, not verbal here. So the state of semi-coma, the patient responding to motor stimuli only, not verbal. And finally, the state of lethargy, which lies between the alertness and the stupor. The patient actually having intact consciousness, intact, arousal, and intact content of consciousness, but the content is not perfect. It means that the patient have difficulty in maintaining alertness. He looks dull, he looks not communicating perfectly. But actually, if the patient is receiving verbal or motor stimuli, he will respond perfectly. These three terms are out of the mentioned spectrum. It is not, they are not involved in this spectrum, but they must be mentioned here because they are related in some way to another to the state of consciousness. What about sleep? Actually, sleep is the normal form of altered consciousness. It's a physiological process. The patient is having no consciousness, but he's actually in a physiological form. It is not our scope today. State of delirium, in which the patient have acute disturbance in attention and cognition. It means that the consciousness here is clouded and not impaired. The patient is having reduced ability to sustain attention to environmental stimuli. It is more or less similar to the state of lethargy, but actually most of the cases of delirium are caused by metabolic problems rather than structural lesions. Mostly are medical rather than neurological emergencies. And the state of encephalopathy, which is a medical term used to explain or describe any diffuse disease of the brain. The term opathy, it means that there is a problem in the brain function. The brain function, of course, include the state of consciousness, of course, include the state of arousal and the content of consciousness. So any state of encephalopathy may affect the consciousness and may impair the state of consciousness. Simple hints about the neuroanatomy of arousal. Simply, we are not going deep in this point, but just we are going to describe two important sites in the brain. The first is the ascending reticular activating system, which is present in the core of the brainstem, and it receives input from somatic afferents coming from all the body. And it acts as a gate that collects the afferents and then project them to both the cerebral cortices through the thalamus and the limbic system. This is a simple graph showing this. This is the reticular activating system present in the brainstem. It receives, as we said, all the auditory and the visual and the somatic impulses coming from all over the body and then projecting them through the limbic system and the thalamus to the whole cerebral cortex, on both sides, of course. So, if the coma to be present, in order to be affected, consciousness in order to be affected, it needs dysfunction of either the ascending reticular activating system or both hemicortices, because if one side is affected, the other side may compensate. There may be simply some affection, some impairment in the content of consciousness, but still the patient is maintaining or apparently looking wakeful. But in order to be comatose, the patient need to, the parts to be affected are the ascending reticular activating system or both the cortices, both the cerebral hemicortices. So anatomically, any central brainstem structures bilaterally, starting caudally from the medulla, cranially to the midbrain, or both cerebral hemispheres may be affected. So, clinically, how can we classify coma or disturbed level of consciousness? I prefer to say disturbed level of consciousness to remind myself and my colleagues that there is a spectrum, not one point to be repeated again. It's not simply conscious and unconscious. So the classification of disturbed level of consciousness may include structural and metabolic, two big titles, the structural cause and the metabolic cause, and each one of them has its specific differentiating criteria, specific clinical findings. And finally, as we write here, psychogenic unresponsiveness, not a major differential diagnostic point here, because it should be left to the last of the list after exhausting ourselves in seeking the causes. We are not jumping to the diagnosis of psychiatric unresponsiveness or the psychiatric problems as a cause of disturbed level of consciousness before we exhaust ourselves looking clinically and by investigations, excluding the structural as well as metabolic causes first. And then if we excluded all the structural and metabolic causes, we can reach the diagnosis of psychiatric unresponsiveness. So the structural causes may be supratentorial, that lesions are present above or cranial to the tentorium cerebelli, and these lesions cause coma by either widespread bilateral disease damaging both cortices, or increased intracranial pressure causing compression of vital sites in the brain, or by herniation, as will be mentioned in the third part of the lecture. The infratentorial causes, structurally also, these are lesions affecting directly the reticular activating system and are usually associated with specific brainstem signs. And metabolic or toxic, which are the majority of causes, may cause diffuse hemispheric involvement and depression of the reticular activating system, but here it is diffuse without focal or localizing findings. So, how can we differentiate each one of them? First, the differentiating features of metabolic coma, simply, it is not a sudden issue. Actually, it is usually preceded by confusion and stupor before the presence of coma and motor signs. So the confusional state or delirium may occur initially, and then the patient, if neglected, may proceed to the state of deep coma. Here, if there is a motor sign associated with the coma, usually they are symmetrical, and this is a key point in differentiating metabolic from other causes of coma. Motor signs or even pupillary reactions are usually symmetrical. It may be associated with some motor findings or some abnormal involuntary movements like asterexis, which are the coarse flapping tremors affecting the limbs. It may be associated with myoclonic jerks. All these typical findings may be present in metabolic coma, and they are actually symmetrical, and there is no localization, no localizing sign. Again, it may be associated with acid-base imbalance. It may be associated with hyper or hypoventilation, but the key point in diagnosing it are the symmetrical motor examination, ocular reflex findings, and pupillary light reflex. All are preserved. If they are preserved, they are symmetrical. Even if they are affected, it is actually a symmetrical affection. It is not a unilateral finding. In some toxic issues, the pupillary reflex may be affected, the pupil size may be changed, but the pupillary changes are bilateral and symmetrical. They are not unilateral whatsoever. The causes of metabolic coma may be categorized under these four items or issues. It may be caused by deprivation of oxygen and metabolic cofactors. It may be due to disease of organs rather than the brain. It may be due to exogenous poisons, either drugs or toxins. It may be actually due to abnormalities in electrolytes. Let's mention some examples for each of these titles. Deprivation of oxygen, simply the hypoxia, hypoxic ischemic insults, actually diffuse ischemia that may occur in cardiac arrest, in state of depressed peripheral circulation in cases of shock, either hypovolemic shock or septic shock or cardiogenic shock, any cause of hypotension that may cause decreased peripheral circulatory resistance and impair the cerebral blood flow collectively to the brain. Hypoglycemia is one of the most important causes of hypoxia that may affect the brain, and if persistent, it may lead to structural damage to the brain. And the acute form of thiamine deficiency in which the patient have some state of encephalopathy in a syndrome known as Wernicke-Korsakoff syndrome. Other organs may be affected also, like hepatic encephalopathy, hepatic coma, kidney injury, acute kidney injury, acute lung injury like carbon dioxide narcosis. In cases of pancreatic lesions may also cause disturbed level of consciousness in severe cases of hypoglycemia or hyperglycemia. Thyroid dysfunction in cases of myxedema. We all know by myxedema coma or disturbed level of consciousness in cases of hypothyroidism. In cases, even the septic conditions, if the patient, in case of septic shock or generalized sepsis, the patient may present with state of encephalopathy, and this is actually one of the causes, as we said, for disturbed level of consciousness. The poisons also, or drugs, of course, are accused of having metabolic problem in the brain, like sedatives, like narcotics, like psychotropic drugs, some heavy metals in case of working in an area, industrial area with exposure to heavy metals, cyanide poisoning, and of course some of the rural areas with the organophosphorus compounds. All these toxins may cause injury to the brain and cause disturbed level of consciousness. And thus the abnormalities of water and electrolytes, of course, are one of the causes of metabolic coma or metabolic disturbed level of consciousness. The structural coma, here we can shift to the other extreme, which is asymmetry, characterized by asymmetry, or simply, let's say, it is characterized by localizing signs. If I'm dealing with a supratentorial lesions, they are some specific localizing sign. The same for infratentorial, so both of them can cause coma by structurally damaging certain parts of the brain, causing either widespread bilateral disease, either increased intracranial pressure, as we said, or by herniation. These are the supratentorial sites, lesions that may cause coma, and the infratentorial if there is herniation through the tentorium causing compression on the vital reticular activating system structures in the brain. The differentiating criteria for supratentorial mass lesions, usually focal cerebral dysfunction. It means that it focus or point to a specific anatomical area. As we said, the motor signs are asymmetrical, and usually it is caused by structural lesion, either hematoma, neoplasm, abscess, vascular accident, contusion. Any structural lesion may cause damage to these specific parts and cause disturbed level of consciousness. The same applies for infratentorial, but here the localizing signs or the differentiating signs are pointing to the brain stem, localizing to the brain stem. And actually, the localizing brain stem signs may precede or accompany the onset of coma. And usually, it includes the oculovestibular abnormalities, cranial nerve pulses are specifically present. The pattern of respiration here mostly is bizarre, and we have different respiratory patterns that will be mentioned in the clinical part of the lecture. And of course, the same causes are accused, the same as the supratentorial, but they are localized infratentorially. To finalize this section of the lecture, we just have to remind that infection, of course, may be an important cause of disturbed level of consciousness. And actually, the differentiating features of infection, if causing or what is called infection-induced coma, the patient having history of infection, having fever, having neck rigidity, having signs of meningeal irritation like Kernig's and Prozinski, and these are collectively differentiating features of the infection as a cause of disturbed level of consciousness. By this, we end the first part of our lecture, and let's have 2 minutes to read this case scenario and try to choose which is the best answer for this case. In this part of the lecture, we are going to speak about the coma differential diagnosis. We will pass through all these titles: the brain death, the persistent vegetative state, the looped-in syndrome, the non-convulsive status epilepticus, and psychiatric unresponsiveness. We'll give small hint about each of them, because they are actually simulating coma in some way or another, and most of them are involving impairment either in the state of arousal or either in the content of arousal. And for sure, most of them are irreversible, irreversible damage to the brain, and of course, each one of them has its specific clinical criteria. Let's start with the brain death. Simply, brain death is a medico-legal term commonly used by many other specialties, not neurology only. And of course, it is a state of irreversible damage to the brain. It means that there is loss of the brain and the brain stem function, but this loss is irreversible. It is diagnosed in a comatose patient with absence of all the brain stem reflexes: corneal reflex, pupillary right reflex, gag reflex, oculocephalic reflex, and vestibulocochlear reflex, with no evidence of spontaneous respiration. the patient, it means that the patient had abnormal bedside apnea test. It means that no observed breath, despite being on 100% oxygen and having PCO2 more than 60 millimeters. These are the diagnostic criteria of brain death. But here we should mention that it is not diagnosed at a point of time. It needs actually to be observed for more than 6 hours in adults and more than 12 hours and up to 48 hours in some cases for children. It means that brain death involves no improvement of all these observations for more than 6 hours in adults and more than up to 48 hours in children. Here, the cause of coma is known and is actually sufficient to cause irreversible brain damage, like cardiopulmonary arrest, for example. Cardiopulmonary arrest, if maintained and the patient is not preserved, the patient may pass through the state of irreversible brain damage, especially if the patient is having CPR for long time and the patient is not responding. The patient may pass through the state of brain death. In case of brain death also, we should exclude any potentially reversible cause of marked CNS depression, like hypothermia or hypotensive shock or drug intoxication, especially if the patient is having some sedative overdose, and severe metabolic problem like persistent hypoglycemia or something like. All these metabolic issues or these reversible causes of marked CNS depression should be excluded before we announce that the patient had irreversible brain damage and the patient is going in the track of brain death. As we said, it is not a point of time diagnosis. It needs to observe the patient for a while. And of course, there are some helpful diagnostic tests that may confirm the clinical diagnosis. Simply the EEG, flatline EEG is diagnostic or helpful in diagnosis. And some investigations, bedside investigations may be done like transcranial Doppler. The Doppler study is simply an ultrasound technique done on a bedside manner. It detects the blood flow through the arterial circulation or the venous circulation. Here in the brain, we are studying the arterial circulation, either extracranially through the aorta and its branches, or transcranially through the intracranial branches of the arteries. And all these arteries, if by transcranial Doppler we didn't find any sign of blood flow, it will help in diagnosing brain death. And also the radioisotope scan like this slide, in which we can differentiate between a normal healthy brain. This is a normal healthy brain with perfect blood flow and perfect circulation. And this is the vegetative state. It will be mentioned in the next slide for sure. This is the state with impairment in the metabolism, but in the blood flow, I mean, but this is still perfused, but to a lesser extent than normal brain. But this is the state of brain death in which there is no blood flow or no perfusion whatsoever. This is the diagnostic picture of brain death. So the second point is the persistent vegetative state, in which the patient the affected part here is not the state of arousal. It is actually the content of the arousal, not the state of arousal itself, if we return back to the very early slides of the lecture. Here, the patient apparently awake, but actually he's not like this. The patient is looking awake, but he's not attending. The content of consciousness is impaired. So the patient here appears intermittently awake with normal spontaneous breathing, with normal spontaneous autonomic functions like gastric, like cardiac motility, like gastric motility. All these parts are intact. The patient have primitive reflexes with severe cerebral damage. And this damage is persistent, causing no meaningful communication or cortical responsiveness whatsoever. So it is a chronic, it's not actually an acute event. Mostly It is an outcome of persistent hypoxia, not treated perfectly, and it will make the patient pass through a chronic state of what is called persistent vegetation. Clinically, it is diagnosed, as we said, by certain points: no awareness of self and environment, although the patient appearing awake, no interaction with others, no evidence of sustained, reproducible, purposeful, or voluntary behavioral responses whatsoever, either to visual, to auditory, to tactile, to even noxious stimuli, no response evident, and no evidence of language comprehension or expression. Intermittent wakefulness in the persistence of what is called sleep-wake cycle. The patient still is able to sleep and wake, but actually when he's awake, he's actually looking awake, but the content of wakefulness, as we said, is not present. Bladder and bowel functions are preserved with some incontinence. The patient has no voluntary control on these functions, of course, with preserved autonomic functions, as we said. The cranial nerve response is variable according to the site of damage. Some may be preserved and others are not. It's not a diagnostic point here, but the key diagnostic point here is the apparently a wakeful patient with no content of arousal, as we said. The third point is the locked-in syndrome, which is selectively and exclusively specific for the damage occurring in the bones. So the patient here, actually it is one of the variants, let's say a variance of the persistent vegetative state, actually. But here the patient has specific selective criteria, which is the intact or preservation of the vertical gaze and eye blinking only. These are the all findings present by the patient. The patient here is unable to move the limbs, unable to move the face or the gaze laterally on side to side, but the patient is actually preserving the vertical gaze up and down and eye blinking only. Here the patient is called deafferented. It means that he's not connecting, his brain is away from the rest of the body. But here the communication and cortical functions only, as we said, are preserved in the blinking and the vertical gaze and not more. The patient may, with time, start to blink and communicate with his caregiver or the doctor by blinking. In some cases, one blink means yes, two blinks may be no, but actually this is not a common finding, but the main finding is the preservation of the vertical gaze and the blinking functions. The cause of locked-in syndrome is mainly an extensive pontine damage, not infarction alone. Any problem that may cause damage to the bones, it may cause a locked-in syndrome. Here in this image, there is an extensive hypodense lesion. It means hypodense. It means that it is looking darker than the rest of the brain, and this is mostly an ischemic insult, an extensive ischemic insult affecting the bones, and of course this patient is presenting with what is called locked-in syndrome. The fourth point, we all know, or we have to know, the status epilepticus. We know that it is a persistent state of convulsing for a while, and if the patient is presenting with a status epilepticus, it is a neurological emergency. In some cases, the patient may present with what is called non-convulsive status epilepticus. It means that the patient may experience persistent, continued, or generalized seizures in the absence of obvious clinical convulsive activity. He's looking not convulsing. He's looking flat in his bed. He's looking comatose or something like. But there is some very minimal clinical manifestations may give us a key that the patient has some sort of non-convulsive status epilepticus. Rhythmical nystagmus in the eye or nystagmoid movement. Some twitches, very minimal twitches in the eyelid or part of the face or part of his upper limb or part of his body in general. But there is no, definitely, the state of convulsions is not evident. The patient is not he's not looking convulsing like the typical status epilepticus. And here, the confirmation may be done by obtaining an emergent EEG, and we start to record the brain activity, and then start to give the patient like intravenous benzodiazepine, one of the drugs used for acute management of status epilepticus, and we will check the function of the brain through the EEG. Actually, this is the typical finding of the status epilepticus. If the patient is given the sedative, it will return back to the normal basal background of the patient brain, and this is a bedside diagnostic test for confirming the issue. The last one, and I repeat again that it is not one of the most important points to be differentiated from coma. We are not jumping to diagnose what is called psychiatric unresponsiveness unless we exhaust ourselves by looking for the other causes of coma, the other metabolic as well as the structural causes of coma first, and then if all are excluded, start to think of psychiatric unresponsiveness. Actually, it is a diagnosis of exclusion. It is not diagnosed except after excluding all the organic causes. No history of drug overdose, intact brainstem reflexes, spontaneous breathing, no focal neurological deficits, normal metabolic profile, normal brain MRI with diffusion weighted sequence. Simply, this diffusion weighted sequence is specific sequence of MRI, specific image that can detect ischemia and other structural damages very early as 1 hour after its onset, and it is actually one of the fast ways to diagnose brain ischemia, stroke, ischemic stroke, and other neurological entities. And of course, normal EEG, similar to the awake state. All these criteria, if present, with a patient looking unresponsiveness, start to think of psychiatric unresponsiveness. And this is the second and last break in our lecture. Another case scenario, try to find the best choice. And this is the third and last and the most important and the longest part of our lecture, actually, which is how to approach a patient in coma or a patient in disturbed level of consciousness. Actually speaking, this patient is not coming to you in your clinic. You are not facing him in the clinic, like headache, like other neurological problems. Actually, the patient is brought to you by his family. So, in order to deal perfectly with this patient, you should start for any comatose or any disturbed level of consciousness with what is called the initial approach. The initial approach for a comatose patient is a standard approach, should be applied for any patient coming with disturbed level of consciousness in order to save the patient. Your first aim and most important and very, very, very important aim that you should save your patient. You should assure that the patient airway, circulation, and breathing is normal, and then start to deal with your patient and look for the cause of the coma. Not starting with what happened to the patient and what actually you should save your patient first, and then start to take all the data from his relatives and from his companions. So the initial approach for the patient here is vital and may be life-saving in more than 90% of the cases, the initial approach. And then after the initial approach, you should start to classify your patient according. If the patient having fever, what will you do? If the patient having focal findings, what will happen? If the patient coming with no focal findings, what will happen? But first, as we said, the initial approach is mandatory in this issue. And there are some golden rules that should be kept in your mind when you are dealing with a patient with coma. First, any alteration in the arousal state, starting from simply delirium down to the deep coma, are considered as emergency. They are all acute, life-threatening emergencies and should be actually presented to the hospital, and there is no management of coma whatsoever at home. And this is to be mentioned because many of the families, especially if they are having an old patient and a grandfather or grandmother in the house, and he starts to have some state of delirium, they may wait for 1 or 2 days, and they say it's a matter of aging, a matter of something like. Just call a doctor to see the patient at home. This is very nonsense, because any patient, any old or even young patient presented with disturbed conscious level should not be mentioned, should be not treated at home whatsoever. You should be transferred to the emergency and starting to deal with the patient as an emergency. Taking the first priority to what is called the ABCs, the airway, breathing, and circulation. Identifying and addressing any life-threatening inadequacies. And actually, in dealing with a patient with coma or disturbed level of consciousness, we should be a multitask doctor rather than a neurologist. If you are a neurologist and sitting in the ER and receiving the patient, you should think more broadly. You think more in a medical way rather than a specific neurological way. Because if we mention that the metabolic and toxic causes of coma are considering around 2/3 of the cases, you should mention that it is important to think of the other non-neurological causes as well as the neurological causes of coma. And of course, the aim of saving or maintaining the ABC, aiming to give the priority to perfusion of the brain, ensuring that oxygen is reaching the CNS and the vital organs, including the heart and other vital organs. As we said, we must address any life-threatening conditions, cardiac or metabolic or other non-neurological causes, and then we should address also the CNS. Because something simple like hypoglycemia, the patient may be diabetic and dropping 1 or 2 meals and coming with the state of disturbed level of consciousness with hypoglycemia. Actually, if the patient received intravenous glucose, it will be perfect and the patient will be saved after doing the emergency one check. So try to be going in a more generalized rather than a neurological approach. Don't forget your neurology, of course, but start to be more broad-minded in dealing with the patient. Don't localize yourself in the causes of neurology only. Try to think of other causes as well. And then after you stabilize your patient, you should evaluate for intracranial hypertension and imminent herniation, because if the patient is having one of these signs, it will be a life-threatening issue and it should be also an emergency point. So what is the initial approach? What is the initial approach for a comatose patient? As we said, the ABCs are important, maintaining airway, breathing, and circulation. It will be mentioned in details in the next lecture, in the next slide, I'm sorry. And as we said, urgently correct any hypothermia, any hypoglycemia, rule out hypoglycemia with an immediate finger stick glucose reading or empirical infusion of 50% dextrose with intravenous thiamine. And of course, if the patient is coming with trauma or if you suspect trauma, the stability of the cervical spine is vital, because if you save the cervical spine of the patient, you may save him from future quadriplegia or some handicap may occur if the patient is traumatized or in a car accident or whatsoever, and he's not stabilizing his neck. The patient may have severe traumatic injury to the spinal cord, causing irreversible quadriplegia, if not affecting the respiration, of course. And of course, there is some basic or what is called emergent blood work. It will be mentioned also in the next slides, in order to be sure that there is no metabolic emergency that can be corrected simply and reverse the story. And then, of course, if the patient having suspected history of drug abuse, you should also approach or order a drug screen for the patient to exclude toxic or metabolic causes. All these issues should be mentioned in, or should be done in a very rapid way as what is called initial approach for the patient. This is the typical measures for airway, breathing, and circulation. We should check for the airway if the patient is talking perfectly or not. If there is any noisy sounds of breathing, it means that the patient may be obstructed and having difficulty in getting inspiration. If there is any foreign body, any aspiration, any edema, any blood, any vomitus, all these items should be checked to maintain the airway. Also of the breathing, if the patient is breathing well in a perfect, in a regular way, or the patient have very irregular or abnormal breathing pattern. Checking the pulse oximeter for saturation of oxygen in the blood. Listen for any abnormal breathing sounds if there is a stridor or something like. And of course, checking for the circulation. The circulation can be checked from the mental status, from the color of the patient, if cyanosed or pale or something like. If the peripheral pulsations are intact or having shock, a patient may be in a state of shock and the peripheral pulse are not recorded. Of course, the heart rate, the cardiac rhythm, the blood pressure, all these issues should be done immediately as a way to maintain the circulation. If you find the airway is patent, it's okay. No. You have to save your patient and check for the next point. But if the patient having a trauma, neck trauma or foreign body aspiration or something like, may be obstructing the airway, try to put an airway. If the patient having a problem in respiration, the airway may be nasal airway, maybe oral airway, or even in some severe cases, the patient may need what is called endotracheal intubation. If the patient is not fully conscious and not able to maintain his airway, we should induce an endotracheal tube as an emergency method. Of course, if there is a trauma or a foreign body obstructing the airway, it should be also removed. And the method to protect the cervical spine, to open, elevating the chin of the patient and trying to open the airway and protect against traumatic insult to the cervical spine. If the patient is shocked, I should here raise certain point. Blood pressure actually is not an early sign of shock. It is a very late, if the patient is hypotensive, it is actually a very late sign of shock. The patient may have some other early signs of shock that are should be noticed before we go for the blood pressure. If the patient is tachycardic, if the patient is pale, if the patient is having some sweating, even if cold sweat, all these signs, the pulse, the heart rate, all this may be very early signs of shock and should be we should catch it very early, because if we wait to the patient to have hypotension, we will wait for a long time and the patient may be lost by this way. In case of shock treatment, we should make a good perfusion to the patient. It means that we don't have to restrict the fluids in the comatose patient, even if the patient is cardiac or something like. Because the cardiac output and cerebral perfusion are of vital importance here. We should maintain the cardiac output as much as we can, and also we should maintain the cerebral perfusion as much as we can to protect against cardiac and ischemic insults. This is much more safe than you restrict the fluids and the patient, you may be lost by this way. So cardiac output and cerebral perfusion are much more important to be saved rather than fluid restriction. So do not restrict fluids. How can we replace fluids? We should use isotonic solutions. Isotonic solutions mean the fluids that are similar to the viscosity of the blood. Simply, we are not going to deep in this point. And of course, if we used hypotonic solutions to treat shock, it may have some problems in what is called the water homeostasis, and it will lead in some way to another to some risk of possible cerebral edema, brain edema, shifting of the water from the interstitial fluids to the inside the cells and causing cerebral edema, and this will of course raise the risk of disturbed level of consciousness and even the coma. So if there is suspicious of hypovolemic shock, we should replace by isotonic fluids. And of course, if there is any life-threatening hemorrhage, either internal bleeding, internal abdominal bleeding, or external bleeding from any way, especially if the patient is coming in a car accident or a trauma, we should identify this hemorrhage and replace as much as we can, either by fresh blood or by even isotonic solutions till we find the blood replacement. After stabilizing your patient, after you are dead sure that the patient is safe, you can deal with the history of the case. Come and sit with the caregiver or the family member and start to have the items of the history in a slow and very meticulous way. But before doing the initial approach, before saving your patient, your first priority is to save your patient first, and then after the patient is saved and you give the patient to one of your colleagues, for example, a head nurse or a junior doctor, you start to deal with the family and start to have the history. Because there is some points in the history that may help you in addressing the cause of coma. As we said, the coma of sudden onset most probably may be secondary to structural damage, an intracranial hemorrhage or cardiopulmonary arrest or embolic cause or trauma, even if observed or unwitnessed head trauma, the sudden onset of coma. The acute onset or the coma preceded by confusion or delirium, you should think of a toxometabolic etiology rather than structural etiology. It may be organ dysfunction, it may be electrolyte disturbance, it may be medical or drug toxicity, and in some brainstem problems may present with acute onset rather than sudden onset, but it's not common. But actually, for our knowledge, acute onset preceded with delirium or confusion should think of metabolic rather than structural. Other important information also should be obtained from the relative. Current medications, especially if the patient is diabetic, if the patient having anticonvulsant therapy, if the patient having drug for heart cardiac problems, any history of adverse or allergic medical reactions, if the patient had recent head trauma, any febrile illness or non-febrile illness, if the patient had previously neurological symptoms or symptoms of coma, of convulsions once before, any use of drug abuse also should be mentioned. All these items should be mentioned in the point of history. And then the physical examination. Of course, the physical examination is one of the vital signs are one of the early signs of initial approach, but after, as we said, you stabilize your patient, you can think backwards or think retrograde for the cause of coma. If you find your patient comatose with a hypertension, you should think of acute cerebral hemorrhage or acute cerebral infarction. If the patient having pure hypertension and the CT brain is unremarkable with disturbed level of consciousness, you can think of hypertensive encephalopathy. If the patient having a history of drug abuse, you can think of cocaine abuse as one of the causes of hypertension. If the lady is coming to you with pregnancy and she's coming with hypertension, you should think of eclampsia. Hypotension, as we said, hypovolemia, cardiogenic shock, or septic shock, all states of shock can cause hypotension. Temperature, one of the most important vital signs. If your patient is feverish, you should think of infection, of heat stroke as cause. If the patient is hypothermic, you should think of cold exposure, especially if the patient is alcoholic. Hypothyroidism, hypoglycemia, especially if the patient having cold sweat. Sepsis, or in some rare primary brain lesions, the patient may present with central hypothermia. Pulse, as we said, is one of the signs of early shock, and also presence of any pulse asymmetry may suspect dissecting aneurysm in the aorta, and this may be a cause of disturbed level of consciousness also. The general appearance of your patient may be a clue for some underlying problem. If you examine the patient head and neck and you find the patient having blood in the external ear, a Patel sign, or blood around the eye, which is called raccoon sign, this may suggest skull fractures. If the patient is having running nose with blood tingled with clear fluid, it may be a fracture base of the skull, and the patient have CNS rhinorrhea, CSF rhinorrhea. As we said, the bleeding around the eye, bleeding in the ear, bleeding, diffuse hematomas in the body, it means systemic bleeding. If the patient is jaundiced or the patient is ascitic, having ascites, the patient may be suspicious of hepatic encephalopathy. If the patient looks uremic, all these findings are characterizing to local or systemic issue should be considered. The level of consciousness is one of the important parts to be mentioned in this lecture, because of course we said in the early slides that it is not conscious and unconscious. It is a spectrum of consciousness. So it is more useful to describe the patient's spontaneous behavior and response to stimuli rather than using these terms. These terms are of academic interest, but when we are in the ER and trying to assess our patient, we should have a scale with a certain specific number or point that a cut-off point. If we are below this point, we are coma. If we are above this point, we are conscious. And this is the function of what is called the Glasgow Coma Scale. It demonstrates a hierarchy of responses in each part of the components of the scale, and each one of them having a certain score, and then we collect this score, having a score starting from 3 in a state of deep coma and ending with 15 in a fully conscious attending patient. And this is what is called the Glasgow Coma Scale. It is divided into the 3 responses: the responses of the eye, the responses verbal response, and the motor response. Starting with the eye response, the spontaneous eye opening giving 4 points. The eye opening to verbal speech or shout, it is 3. If the eye open to pain when applied to the body and not to the face, giving the 2 points, and if there is no eye opening at all. Same applies for verbal response. If the patient is oriented and communicating, giving full score 5. If the patient is conversing but in a confusion state, but still able to answer the questions but in a slow or confusional form, giving 4. If the patient giving inappropriate words or inappropriate responses, giving 3. If the patient just giving incomprehensible sounds, is 2. If the patient has no verbal at all, verbal response at all, it is 1. And the motor response starting by obeying commands with full movements, this is 6. If the patient is still on painful stimuli, having some purposeful movement, trying to move, it is 5. If the patient just withdraw to pain, it is 4. If the patient start to flex in response to pain, it is 3. If the patient extend in response to pain, it is 2. And if there is no motor response at all, it is 1. And this is the scales starting with minor brain injury from 13 to 15, moderate from 9 to 12, and severe brain injury or coma starting from 8 going down. So coma is diagnosed when the Glasgow Coma Scale is less than 8. This is another graph for the Glasgow Coma Scale. The pupils. Actually, the eye in the coma is the mirror of the brain in most of the cases. The pupillary response and the pupil itself may be affected in many different issues. For example, if the patient having a parasympathetic lesion affecting the oculomotor compression in ankle herniation, the patient may be dilated asymmetrically. It may be dilated and no reaction to light. If the patient having sympathetic lesion, Horner syndrome, the eye may be myotic. If the patient having bilateral pinpoint pupil, if the pinpoint pupil is looking bilateral, it is actually a metabolic problem, mostly opiate intoxication. If unilaterally, it may suspect a unilateral brainstem lesion, pontine hemorrhage. So the pupillary reaction actually in this graph may be, as we said, a clue to many underlying problems in the brain. As we said, just remember that the asymmetrical pupil reaction raise your suspicion of a structural lesion rather than a bilateral and symmetrical structure. Bilateral and symmetrical structure usually is a metabolic or toxic rather than a structural lesion. With some exceptions, of course, the neurology and medicine in general has no 100% rule. Every rule has some exceptions, but we are speaking about the most common. What is common is common. The eye movement also, it may help in guiding you to a structural problem. Actually, the patient with preserved ocular reflexes, oculocephalic or vestibulo-ocular, if are present or preserved in a comatose patient, it means that this patient has a still preserved brainstem function. Eyes disconjugate at rest. It means that there is some paralysis of certain muscles, either single muscle or internuclear ophthalmoplegia or whatever, and this applies for even comatose as well as conscious patient, of course. Conjugate lateral deviation of the eye towards one side. It may be also a clue. It may look for the contralateral brainstem lesion or for the ipsilateral cerebral hemisphere. It means that if the patient has a lesion in the right hemisphere, both eyes may look to the right, and of course the opposite for the brainstem. And of course, the persistent rhythmical nystagmus may be a clue for subtle finding of what is called non-convulsive status epilepticus. Plinking also is important because, as we said, locked-in syndrome, the plinking is only, and vertical eye movement is only the preserved function of the eye, and spontaneous blinking also may indicate that it is an intact reticular activating system, and this is important in differentiating definite structural coma from psychiatric unresponsiveness. And of course, fundus examination helps in papilledema, detecting an increased intracranial pressure. The respiratory pattern. Actually, the respiratory pattern is very important also. It helps in differentiating many different types of metabolic rather as well as a structural coma. Starting simply from the breath of the patient. If you find acetone breath in the patient, you should think of hyperglycemia. If we detect alcohol in breath, or fetor hepaticus, hepatic breath, these specific smells may guide you to an underlying problem. Observing the state of hypo or hyperventilation, as we said, helpful in diagnosing the patient, especially if we attend the patient with blood gas sample. Correlate the pattern of breathing with the blood gases, arterial blood gases. It will help in guiding you to a metabolic problem, if any. And also, there are different respiratory patterns that may be helpful in localizing some issues, like what is called kinestoke respiration. It is simply periods of hyperventilation alternating with apnea. Hyperventilation alternating with apnea. This is a pattern what is called crescendo-decrescendo fashion. And this actually is diagnostic for bilateral cerebral diseases, and also it helps in diagnosing impending transtentorial herniation and upper brainstem insults. The sustained hyperventilation, usually it is a metabolic rather than a structural. If the patient is maintaining hyperventilation with pulmonary congestion or hepatic encephalopathy or metabolic acidosis, usually the patient presents with sustained hyperventilation. We are not going to go in further details, but there is some irregular pattern of breathing, like what is called ataxic breathing, variable irregular rate and amplitude of breathing. It is actually a medullary damage. And apneustic breathing, it means that the patient has some inspiratory pauses, and this is specific for pontine lesions. This is a graph collecting the different respiratory patterns in normal and abnormal issues. And these abnormal issues include respiratory and central causes also. So the next section of this part is the coma and brain herniation, which is very important and very critical. As we said, the herniation of the brain may occur through what is called the phalanx cerebri, which is the partition dividing the two hemispheres, separating each from each other, and the tentorium cerebelli, which separates the supratentorial structures, the hemispheres, from the infratentorial structures, mean the cerebellum, and the brainstem. So the transtentorial herniation may occur with expanding supratentorial mass lesion, and also there may be what is called midline shift, and it means that one side of the hemispheres, one hemisphere is extending and compressing the other and passing through the midline and causing midline shift. So we have traditional signs of herniation, the ankle pattern of herniation starting with unilateral structure, and actually it causes, as we said, unilateral dilated unreactive pupil, and the central herniation, which may affect the state of consciousness and cause impairment in the state of consciousness. This is the graph that we describe. This is the lesion. It may shift to the other side, causing what is called midline shift. It may pass through the transtentorium, causing what is called transtentorial herniation. And in the central structures, if the supratentorial structures passing centrally, causing downward herniation of the supratentorial structures, causing what is called central herniation. These are some imaging examples. This actually is the state of transtentorial herniation of this side. This is the midline shift, sizable hypodense lesion. This is the lesion, mostly it is an ischemic lesion, and it is associated with edema and compression that cause the hemisphere to be shifted to the other side and causes what is called midline shift. And this is the subphalangeal herniation of the structure. Here is not in the last study, the whole hemisphere is shifted to the midline, but here there is structural lesion passing through the phalanx cerebri and causing subthalassine herniation. This is a collective slide showing the signs of increased intracranial tension and herniation. As we said, the pupils are unilaterally undilated. It is suspicious of ankle herniation. If the pupils are bilaterally pinpoint, as we said, it is a pontine problem. The eye movements also, if there is a localized focal nerve lesion, cranial nerve lesion, it may suspect also state of herniation, and the fundus examination, and of course, as we said, the respiratory pattern. We are still having some parts in this lecture. This part is the motor examination of your patient. As we said, the motor part is done through the Glasgow Coma Scale assessment, but here it is important also to assess the muscle tone, as well as if there is any abnormalities in the abnormal involuntary movements also. It may help in diagnosing the issue. The reflexes, the symmetry and asymmetry of reflexes, all these items are mentioned to differentiate again from the structural from the metabolic causes of coma. As we said, asymmetrical limb movements or asymmetrical muscle tone usually occur with structural brain lesions, and there is some abnormal postures indicating the state of coma. If the patient having a flexed upper limb posture, this is called what is called the decorticate posturing. It means that the cortex of the patient is detached from the other brain parts, and this is usually seen with the supratentorial lesions. The decerebrate part, this is the extended form, which means that the supratentorial structure is detached from the infratentorial structures, and this is what is called the decerebrate posturing. Presence of myoclonic jerks, as we said, or asterexis, as we said, the metabolic causes of coma. This is a picture of decortica and decerebrate postures. Well, after we finish the, investigations of coma are not done after we finish the examination. Actually, as we said in the initial approach again and again, the investigations are going parallel to the examination. In some issues, we are going to have a blood sample and send for lab. This is an emergency, and this is actually a point of initial approach to the patient. So we cannot say that investigations are done after we finish the clinical assessment. Actually, each one of them has its perfect time to be done in the approach to perfectly save and protect your patient. Here in the investigation section, we are just going to pass through the investigations and mention which of each, when to choose an imaging, when to choose lumbar puncture, and so on. Imaging, I mean CT or better MRI. Of course, CT is much more commonly present in most of the primary care hospitals, and so it is a very early and very rapid imaging method, just to exclude hemorrhage, exclude signs of brain herniation, signs of increased intracranial tension, because these are very mandatory before going for lumbar puncture. For example, we are not able to do lumbar puncture perfectly before we do a CT brain for a comatose patient, to exclude brain herniation and to be safe when dealing with your patient. So CT or MRI are done if we are suspecting a structural problem, as we said, or suspecting a focal lesion. Lumbar puncture also if the coma is not explained by imaging, or the imaging may be, as we said, imaging should precede the lumbar puncture. In one very rare situation, we can proceed for lumbar puncture, and we are justified not to wait for the imaging. If the patient having no signs of any herniation or suspecting any mass lesion perfectly by examination, and very emergently we are suspecting an infection or something like, we can cause a spinal tap without waiting for the CT or MRI. But it is actually, for our knowledge, not the ideal situation. EEG, of course, is an important diagnostic method. As we said, it was mentioned in many cases in the non-convulsive status, in the brain death. So it can simple as distinguishing coma structural from psychic unresponsiveness and locked-in state. Also, it is important to be mentioned that it is importantly to be checking what is called the background of the EEG. The structural activity of if there is suspicious seizure activity or non-convulsive status, it will be seen in the EEG. But actually, the background of the EEG, it's a specific finding to be read in the EEG. The symmetry of the background may help in distinguishing structural from metabolic causes. If there is bilateral, symmetrical background slowness of the EEG, it is usually suspecting metabolic cause. If there is asymmetry, it may suspect structural or seizure activity. And of course, the most important and most rapid one is the emergency lab. Emergency lab studies, there are many specific tests that should be done immediately, and here this is a collective slide of the asked labs to be done. The immediate tests that like glucose, like electrolytes, like CBC, blood urea nitrogen, creat, osmolality, ABG of the patient, and if we're suspecting lumbar puncture, if we're suspecting infection or something like, we do a lumbar puncture. All these are immediate tests. There are some other deferred tests that can be, not to say delayed, but they are not done as an emergency rule. It may be we can wait for stabilizing the patient and then ask for these tests. If the patient is having some drugs like anti-epileptic drugs or some drugs for cardiac problems, blood ammonia, coagulation profile, liver functions, other liver function tests, all this should be deferred or may be deferred to wait after stabilizing your patient. I think this is the last part of our lecture, how to manage coma. It is a collective review to what all we said. We are not going to give further details. If you are dealing with a patient with fever or comatose, a patient with suspecting septic condition, the initial approach is mandatory for all the patients. CT brain. After CT brain is done and is contraindicated, we can do urgently lumbar puncture to exclude CNS infection. And once lumbar puncture is done, we are justified, if we are highly suspecting infection, we can start immediately empiric treatment just after tapping. After doing CSF tap, we are justified to start for the antibiotic or the viral or whatever the choice before we wait for the results of the lumbar puncture, and then adjust the treatment after the results of culture and sensitivity tests will appear. In a comatose patient with focal findings, as we said, or when we are suspecting a structural lesion, also after the initial approach, the first option, the first priority is the urgent to do a brain CT imaging without contrast to exclude hemorrhage and exclude structural causes, and then we are going to investigate for other causes. If the patient CT is normal, we have one of two options. If we are suspecting acute ischemic stroke, as we said, we can proceed to stroke management protocol. And of course, if there is no clinical suspicion of ischemic stroke, we can order MRI brain with special techniques to exclude the structural lesions like infection, like abscess, like tumor, and other causes. If brain CT and MRI are normal, we can proceed for EEG to exclude non-convulsive status epilepticus or post-ictal state. And of course, if EEG is normal, we are exhausting ourselves, as we said, with all the other possibilities, and lab is normal and all other issues are normal, we can start to think of psychiatric unresponsiveness, as we said. If the patient is coming comatose without any focal findings on neurological examination, suspecting metabolic or toxic causes, after the initial approach, we should start, especially if we or if we receive the history of being a drug abuser or having some drugs in his past medical history, we should think of intravenous naloxone as an antidote for narcotics, or flumazenil as an antidote for benzodiazepine overdose if we are suspecting each of them. If no toxic or metabolic causes become obvious after full lab investigation, we can start by doing a brain CT or brain MRI. Actually speaking, here you can find that all the issues should be covered, but when to start with, because it is a matter of time in all the issues of coma, and even actually in most of the neurological problems, time is crucial, or time is brain, as we usually say. This means that all the investigations are available, but when to choose which of them is the key of art here. This is the differentiating from one clever doctor and another. This is the point. If we are dealing with a patient and we are suspecting much more that it is a metabolic problem, we should start with lab before the imaging. And of course, the opposite is right. What about the prognosis of coma? Coma actually is not a disease, is not a clinical disease entity, a single entity, I mean. It means that prognosis of the coma depends on the cause. If the patient simply is having a very mild head trauma and having a transient coma for what is called post-concussion or whatsoever, and then the patient coming perfectly attending and perfectly doing, it is a very, very good prognosis. If the patient is having hypoglycemia and this hypoglycemia is perfectly managed in time, the patient may pass normal and will not have any residual problem. If the patient even had a very emergent management to cardiopulmonary arrest, this is the worst cause whatsoever. If this is a transient issue, if the patient is receiving the cardiac shock treated perfectly and the CPR was done perfectly and the patient had, of course, the chance to pass, he will pass and it may not leave any residual damage, especially if the approach was done within 2 or 3 minutes and didn't reach the time of 5 minutes, of course. So the prognosis depends on the cause and depends on the surrounding issues. As we said, the non-traumatic coma mostly have 15% satisfactory recovery, most of the cases. The best outcome in the metabolic causes, as we said, like hepatic, like hypoglycemia, like this. The intermediate prognosis, and here we can say it is from intermediate to guarded prognosis, actually. The hypoxic ischemic insult. If we said the cardiac arrest, if treated perfectly before 5 minutes, it will pass in a more or less less devastating way. But the worst prognosis actually is with the diseases that cause structural damage, either cerebrovascular disease like persistent cardiac arrest, if persisting more than 5 minutes without perfect CPR, this will carry the worst prognosis whatsoever. Most of the drug-induced coma, as we said, is reversible if we treat perfectly with the drug and give the antidote if available. And the traumatic cause, as we said, depends on the initial degree of neurological abnormality. It means that if the patient with trauma is presenting with very simple trauma and there is no definite damage of the structural parts in the brain, it will pass without a problem. But if the trauma is much more severe, causing herniation, causing brain damage whatsoever, it will do worse. But collectively, you can say that traumatic coma patients may do better than the non-traumatic coma patients if treated perfectly. And this is the last question in our lecture, and by this we reach the end of our lecture, and thank you for attendance.